Thank you everyone for joining our last but not least event of the Women in Health series. Today, Dr. El-Khatib from Fibris will be giving us the talk on AI in digital health and the role of Fibris in pioneering the field of AI-powered healthcare system. Rafah El-Khatib is a machine learning engineer passionate about doing AI for good. She works at Fibris, a health tech startup whose mission is to bring AI-powered diagnosis and accelerated treatment access to every household around the globe. The speaker received her Bachelor Engineering in Electrical Computer Engineering from the American University of Berlin, AUB Lebanon in 2012, and her PhD in Information and Coding Theory from the Swiss Federal Institute of Technology, Lausanne, EPFL, in 2016. Her experience and interests include the design of predictive models, Bayesian networks, deep learning, feature importance, and unsupervised problems. Everyone, please welcome the speaker of the day, Dr. Rafah El-Khatib.
Thank you very much for the introduction, Jean. Happy to be here today. As Jean said, my name is Rafah. I work at Fibris, and today I'm happy to talk to you a little bit about what we do at Fibris.
Yeah, it's good now.
Great, thank you. So as Jean mentioned, I work at Fibris. I'm a machine learning engineer. And today I'm going to talk to you about what we do at Fibris and specifically how we develop AI solutions in community settings. What are the opportunities there and what are pitfalls? And this is based on my experience working in this domain. So first, I'm going to start with the vision at Fibris. So we are a small group of individuals who are very passionate about our mission to our vision and mission. The vision being, we want to see a world where no one suffers from treatable conditions simply because they cannot access a doctor. And believe it or not, this is a bigger problem than we know, than we can imagine. So for example, there are more than 1 million children who die of pneumonia every year, although this is a very commonly treatable disease. So if you look at the words in this statement, you can notice there are three main words: treatable, access, and anyone in the world. So if you have to think of a solution that can tackle these problems, then we believe that there is no other way to do it besides by using AI. So this is why our mission is to bring AI-powered diagnosis and accelerated treatment access to every household around the globe. So just to start out with some introduction, we are working on bringing artificial intelligence in community healthcare. What is community healthcare? That is, by definition, everything that's non-institutionalized healthcare. So that's not in hospital settings or clinical settings. So that means that it could be in an elderly care home, or it could be in a community clinic, a public open clinic, or it could be in people's households. So what is the problem we're trying to solve? Well, first of all, there are some requirements in terms of AI in healthcare. When we want to deploy AI in healthcare, we need to satisfy the following. First of all, our AI predictions have to be correct. They have to make accurate predictions and not make mistakes. Second, these machine learning models or AI models have to be properly validated. So they have to not have bias, and they have to be validated against ground truth labels so that we know that our machine learning models are learning what they are supposed to learn. And finally, it should be scalable. This should provide equal healthcare to everyone on Earth, which is related to the fact that it's not biased to any one particular population, but it also has to be accessible for everyone democratically. But there are some extra challenges when we want to implement AI in community settings. And there are challenges for each of these three points. For example, in community settings, we have noisy data. because the environment is unpredictable. It could be a local community clinic where there's a lot of people talking in the background. Or you could be using AI models running on hardware that is very low cost, or a different type of hardware. The data could be very scarce, and actually it is very scarce. There is very little data collected for community settings. Most of the healthcare data that is available publicly or privately comes from hospital settings. And even more challenging there is the fact that we don't even have labels. So even if we do have data, such as data from digital devices, medical devices, we don't have them labeled as so that we can train our models on them. And finally, in terms of scalability, different communities have different clinical needs. So it could be that one community has a problem of childhood pneumonia, but another community has a case of common frailty in elderly people, and there are very different needs. So providing equal healthcare to all is not easy when we're applying it to community settings. So I'm going to walk you through how we at Fibris have visualized and envisioned the idealized AI framework in such community healthcare settings. So I'm going to walk you through the core components that are needed in order to successfully build an AI-based remote patient monitoring system. So based on the first point we just discussed, we have noisy data in community settings. So the first thing we should do is to collect data and improve its signal quality. And this boils down to three main points. First of all, capture digital data using digital medical devices and evaluate their quality. Are they bad quality, good quality, should we fix them, etc. And the second point is to clean them. So if there is any noise that we can remove so that we can better interpret the signal, we should remove this noise or at least reduce it. And the third point there is to flag what we have observed. So if the user is using our product and is relying on interpreting these signals to make clinical decisions, we should flag them to the quality of the signal. Is it worth trusting it or not? So this should inform their decision-making. The second step in this framework is, now that we have cleaner data, or at least evaluated data in terms of quality, we can now extract symptoms and vitals from it. So vitals means biological vital signs like temperature, blood pressure, heart rate, things like that. And using these clean signals, we can then build models to extract these clinical signals from them. And you can also extract biomarkers from them. So that could be classification of whether or not a cough exists in this signal, or whether this patient is showing a particular symptom. So now we're starting to build the building blocks of the next step, which is diagnosis, supporting clinical decision-making and healthcare. And so now that we have the ingredients that we've captured or extracted in point 2, then we can support clinical decision-making that can be used by any user of this product. And this has many implications. So for example, in a community setting, when a person is in a community and there are patients with them, they can better triage or classify patients based on severity. And they can better figure out what is normal for each patient because of the extracted symptoms and vitals and the assessment, the automatic and AI-powered assessment of this patient. So this way they can personalize the care, and they can personalize the care plan, which is the treatment, medication, etc. And on the other hand, from a doctor's side, which is not the community side, this doctor can receive all of these signals and then receive a prioritized list in terms of severity or risk, or can also receive AI insights into deterioration, whether a patient has been shown to deteriorate over time, whether an entire community is having an outbreak because they share common symptoms, or whether with personalized care, this patient would not flag anymore as an emergency when they're not, which would reduce anxiety, and hospitalizations. And finally, they can also improve their diagnostic decision-making because of this better informed data that they have. And the last point of this is a direct effect of the previous point, which is that if we assess patients in a better way, in a better informed way, then we can reduce unnecessary hospitalizations and also take people to hospital when they actually need it, so we can detect emergencies early. So if you just look at these 3 steps, you might think, yeah, that's the entire pipeline of how healthcare should work in community healthcare or even outside of community healthcare. But the thing is that these are all user-oriented steps, and they don't happen in isolation. There's a lot that happens in the background that the user does not see. And these are fundamental characteristics of a successful remote patient monitoring solution. So the first point in those is to build gold standard data sets. So when we are training a model, whether it's a model to measure vitals or extract biomarkers or to diagnose or anything, we need to make sure that we're training our models against gold standard labels. And this is an issue in healthcare in the sense that they are very hard to come by. But we believe that an idealized AI framework has to make sure that they're always using gold standard labels, even if they're very difficult to obtain. And the second point in that is something I will talk about later on in the talk, which is that for the existing gold standard labels, sometimes they are imperfect and they have flaws. And our role as well as any person working in this field is to challenge the status quo and try to improve the standard of clinical care by identifying these flaws and improving gold standard labels. Another thing which happens in the background, I guess, but actually is sort of a common thing across everything we should be doing, is to sort of give back to the community. So these users that are using the product, we have a responsibility to improve to upskill them based on what we have learned about their behavior. For example, the users that are capturing the digital data, if we have noticed that they are capturing signals that are noisy, then we have a responsibility to help them improve their capture skills. And also in terms of clinical, in a clinical sense, whatever we are observing from a clinical sense like triage or personalized care, we have a responsibility to give back to the user and to teach them how to personalize care on their end. There's another point where we can upskill users, which is the fact that we are collecting a lot of digital healthcare data. And this is also a rarity. So we have a responsibility to give back to the clinical and academic community by exposing people to this kind of digital data and upskill the healthcare community in a digital sense. And finally, in line with our mission, we have to embed the ease of scalability into our product. So first of all, providing equal healthcare for all across different populations and different clinical needs. And the second point is that the users of such a product should be any person. We shouldn't discriminate based on any technical or clinical skills if we want healthcare and good healthcare to reach all different places in the world. So instead of showing you how we at Fibris fill in or respond to each of those requirements, which might be another long slide, I'm instead going to run you through a few visual slides to explain what the product does and how we have designed our system. So Fibris is an offline end-to-end product. And by offline, I mean that it can work without Wi-Fi connections. That forms a digital bridge between communities and doctors. So as you can see from this slide, on one side, we have the carer and the community worker who is present in the community. So basically that could be a village or a care home or a household. And this person has an app which they use to take checkups of a patient. And on the very other end, we have a doctor who's able to see the results of this checkup and all of the AI insights from their computer screen. And on both ends, we have AI-powered decision support, and we have bidirectional information transfer. So any insights that we have, we share with the community or community worker and with the doctor, but also any of their insights are shared bidirectionally. So this creates an end-to-end system where the patient's whole healthcare life cycle is all in one place. So who are our target communities? As we mentioned, our target communities are all communities, but we had to start somewhere. So what we started with was the most vulnerable patients, and these are children and elderly people. So those two types of communities are the two communities that are most in need of healthcare. So they actually use up the healthcare system the most. But at the same time, they are the least represented in terms of modern technology in healthcare. So in terms of wearables that can calculate how many steps you've taken, or where you can monitor your heart rate from your phone, etc. These are not very easily used by children and elderly people. So those are the two types of communities that we started with. We had our pilot in Mumbai in India in 2017, and then again a case study in 2019 for children in slums. And there we did an evidence-based triage for common childhood diseases. And we were able to detect the presence of respiratory diseases with 97% accuracy. And then when the pandemic started, we also started another pilot in the UK in elderly care homes. And there we were doing evidence-based triage for elderly patients with comorbidities. And we were able to reduce the avoidable burden on healthcare services from 12% to 2%. So just to give you a bit of an idea of what we do and how we achieve these goals, I'm going to show you a little bit what a checkup looks like. So a checkup happens in the community. That's the community worker that executes or does these checkups on a patient. And it's an AI guided experience enabling the capture of high quality medical data. What does that mean? It means that at the beginning, we have a questionnaire with just yes/no answers so that we can determine the general state of the patient. But then we also rely on digital signals that we can later interpret rigorously. And these are captured by 4 different digital medical devices. The first one is a thermometer. The second is a pulse oximeter, which we put on the fingers. This one measures the modulation of the oxygen in the blood when a person is breathing. The third one is a blood pressure cuff. And the fourth one is a stethoscope, which is used to record audio signals of the lung sounds, of the breathing sounds. So I'm hoping that this video works, but I guess we'll see. I'm going to show you what a checkup looks like in reality. So how do we go through the previous steps that I just showed you, and how this is designed in a user-centric, user-accessible format. If the video doesn't play, please let me know. So here we have a patient, it's a random name, Jane Smith, and we're choosing to do a reactive checkup because the patient does not look well. So then this checkup runs us through the questionnaire. So here it looks like all of the emergency questions were answered with a no. And then we go through different kinds of questions. So some observations, they're fully awake, yes. They react when we talk to them, yes. These questions were chosen based on clinical research. And then we have general health questions, nervous system questions, respiratory health questions. So we're answering no to everything. And we'll see that with the, because we answered no to everything, the patient looks fine overall. So we just say, okay, just administer routine care. It doesn't seem like this patient is unhealthy or has anything wrong. But here, as you see, we're changing some of the answers to yes. And this then doesn't tell us, okay, routine care. It instead takes us to a different panel of the digital measurements that we can take for the patient. So here, for example, we are connecting with Bluetooth to a blood pressure cuff, which is now connected and it has taken a measurement. We then go back to the panel. In any order, we can choose another type of measurement. So here we're connecting to the pulse oximeter and the stethoscope, again via Bluetooth. And now the recordings are being taken. So with a stethoscope, we take up to eight digital recordings of the patient's chest and back. And as you can see now, if any recording is noisy or of bad quality, then we flag to the user that they have to take another signal. They have to retake the measurement because we couldn't interpret it. We couldn't extract any breathing signal from this signal. So the recording is taken now. Then we move on to the respiratory rate. This one is taken manually by the community worker, which we will talk about a bit later. And then finally, the temperature is taken with a digital thermometer and then recorded manually. So this checkup is now complete. Again, we land at routine care, but this time we are sure that it is routine care, even though some of the questions in the questionnaire have flagged as slightly alarming. But now we are sure from medical signals that there is no need for further action. And so the community worker says, I will not take any further action. And this ends the checkup here. So as we saw in the previous slides, the checkup ends here. So that's on the community worker side, but that doesn't mean that the patient's journey ends here. On the other side, who receives this information? Okay, the community worker took a decision. There is no need for further action. But what if a doctor feels otherwise? So a doctor can also see everything about this checkup from their portal, from their computer screen, and can remotely monitor a patient using this platform. And this has been, for example, with COVID, has been critical in treating patients remotely. So on the doctor screen, we have an AI-supported decision-making platform where the doctor can see a lot of different things about the patient. For example, a risk stratification. They don't see all of the patients in a random order, rather they see them classified by risk potential. Then they can actually carry out the checkup virtually. They can listen to all of the recorded signals and they can get AI insights about them. And finally, they can monitor the patient longitudinally. So they can see how their checkups progressed with time, whether there are signs for deterioration, whether they should personalize care for this patient so that their normal ranges are specialized to them. They're probably different. They could be different from other patients' normal ranges. So instead of, if you remember the idealized AI framework, instead of going through all of the ways in which we respond to that, I'm going to run you through a case study about respiratory rate, which we saw in the checkup as manually inserted by the community worker. So how do we as Fibris tackle this issue of measuring respiratory rate accurately? So just as a reminder, the respiratory rate is the number of breaths that a person takes in 1 minute. And it is a very important vital sign to collect and log accurately because it's crucial in detecting deterioration early and in diagnosing serious respiratory illnesses such as childhood pneumonia. And the current gold standard for measuring respiratory rate, so this is the clinical standard for how it should be measured in clinical settings, is to look at a person's chest and count the number of times that the chest rises and falls within 1 minute. But as many academic and clinical studies have shown, this is a flawed way to count respiratory rate. There are many studies that have shown that even trained nurses make mistakes very often in measuring respiratory rate using just manual counting of chest rises and falls. And one of the common trends in data that we see is that people usually record 20 as the number of breaths per minute, just because this means that the respiratory rate is normal. So typically what community workers do is they say, this patient looks normal, I'm just gonna write down 20. So in order to show you why this is a flawed mechanism, I'm going to show you this video. And this is a video of an elderly person for which we were running a checkup in the community settings. And there are community workers here counting the respiratory rate by observing the chest. So we're taking videos to show them to clinicians and to build a gold standard label. So I'm going to run this video. And if you could please focus, I'm just saying focus because it needs a lot of concentration. We have to repeat the video many times ourselves to determine that. But if you could count the number of breaths in 30 seconds, I'm just going to run it for 30 seconds, and then enter your count into the chat. And then we can compare your answers and we'll see how much they vary. So just to give an idea of breaths, that means that if the chest rises and falls, so this cycle of rise and fall is 1 breath. All right, I hope you're ready. Let's go. All right. When you're ready, please send your counts through the chat and I'll try to read them out for you. Okay, I'm getting 11, 13, 13, 14, 11, 12. I also asked my colleagues and we gave 12, 13, 13, and 15. So this is an open problem. It's a big problem, sorry. And yeah, this basically, we are proving together that this is a flawed mechanism. Even after watching it several times, people can still disagree about what is the correct respiratory rate. So just to give a bit more context, there's a study here that we quote here by Samler et al. From 2013 that shows that 72% of respiratory rates that are logged by nurses are either the values 18 or 20, because those are the two most normal breath counts. Whereas out of the 72%, only 13% were confirmed to be true by trained observers. And actually, this is a study, but we saw the exact same phenomenon in the UK care homes. So this is a histogram of the respiratory rates we've seen our community workers and elderly care homes record. And as you can see, there are 2 large peaks at 18 and 20, whereas for 17 and 19 and 21, these are very low. Whereas what's expected is that the respiratory rate will follow a Gaussian distribution. And if we gather ground truth labels for these, we'll see on the right-hand side a plot where we compare the observed community worker manually counted respiratory rate with the ground truth label. And we'll see that for the category 12 to 20 breaths per minute, which is the normal category, 4% are undercounted. So in reality, the true label is less than 12. 62% is in the correct range, but in 24% of the cases, the true label is actually higher than 20. This is quite alarming because higher than 20 indicates that this patient is unwell. And when you're undercounting the respiratory rate and logging it as 18 or 20, you are probably missing an incident. And in 10% of the cases, the true value is even higher than 24. So that's even more dangerous. You can see that across the board, across the different annotations from the community workers, mistakes are being made. So this is definitely a problem that we should solve in our healthcare community. So how do we solve it in Fibris? If you remember, this is the idealized AI framework. And I'm going to run you through this example. So the first category was improving data and signal quality. So what we do here is we have the community worker who's recording the digital signals, but also they are manually counting. So we ask our community workers to manually count. And we ask them to capture the digital signals using the stethoscope and the pulse oximeter and other sensors. And this is an AI guided capture. So we have models that sort of teach the community worker how to properly capture these signals. And we provide feedback on how to position the probe and on different artifacts. Then we also provide feedback for the care about the manual counting. So we say, based on our analysis and our models, we suspect that you have counted wrong. Would you like to count again? Or also we can say that actually we were not able to interpret the signal because the quality was poor. Can you please take another signal? So we have a feedback mechanism to ensure that we are really extracting the correct values. And then the second step would be to, now that we've captured the signals, can we extract vitals? And so each of these paths would output one value for respiratory rate, the manual one and the AI models one from our device. And as we saw before, our path doesn't end there. We also send these results to a doctor or a clinical expert who can then better take clinical decisions. So this includes the automation of personalized care, the severity stratification to see how risky this patient is, to see whether we can detect deterioration trends, and to better diagnose respiratory diseases. And as we mentioned before, we cannot do this in isolation. So how do we, oh, sorry, I missed a point, which is that also within this entire framework, we don't only have this unidirectional propagation of information, we also have a monitoring system that rolls over the entire pathway and monitors the product to make sure that it is acting in a safe way and that we're gathering insights that help us improve our models with time. So we do this with gold standard data sets, which means that we train our AI models on gold standard respiratory rate labels. But since that definition is slightly flawed, what we do is also we establish robust clinical gold standards. So what we are doing now is we are collaborating with clinical experts from around the world, and we're crowdsourcing annotations from all different types of expertise and all different levels of clinical backgrounds. And we are establishing our own gold standards. We are also running some clinical studies, as you saw from the video in the last slide, to establish the difference between each of these methods and to prove using evidence what the gold standard is. In terms of upskilling users, there's the feedback loops that can improve the community workers' skills in counting and in capturing digital signals, but also by the previous point where we are establishing robust clinical gold standards, we are building a community of annotators of different expertise levels who can collaborate with each other and learn from each other, but also who are exposed to a variety of digital signals so that they can upskill themselves in terms of digital healthcare. And lastly, embedding ease of scalability. This is an underlying characteristic that we always follow in terms of making sure that our models are trained across very diverse data so that they generalize across populations. So for example, with our AI models that we use for respiratory rate, we train, for example, on elderly care homes, but then we validate on children data sets in India. So that's extremely different data sets, but we make sure that our models generalize across the board. And finally, we ensure that in our product design and in terms of usability, anyone can use the product, whether they are clinical or not, and regardless of their technical skills. So again, following the example of respiratory rate, what is the impact of what we're doing? So just to note that this is a project that is in progress. We have done a lot, but we have not finished yet. But still, we can already see a lot of impact. So for each patient, we can correctly evaluate and personalize treatment, and we can allow doctors to give better diagnoses and to detect deterioration. So if you remember this plot from a few slides ago, where the manually counted respiratory rate had two big jumps at 18 and 20, the AI-derived respiratory rate sort of fixes the gaps and takes it back to a Gaussian distribution. So that's the green histogram there. But also, in terms of a bigger picture, what is the impact on the healthcare system? We are helping in detecting severe episodes that could go unnoticed with manual counting. We are reducing a lot of operational waste for the healthcare system. And overall, we're achieving a higher standard of evidence-based clinical care. And to show a little bit of an example about that, there is a study by Wagner et al. In 2010 that shows that a trained nurse in a hospital has an error rate of 6 to 17% when capturing vital signs readings using a paper-based system, so manually counting respiratory rate or vitals. So we have synthesized some data to measure the cost of such errors. And here you can see that even with 3% of error, you can save up to £1,600,000 on the healthcare system in the UK by fixing an error rate of 3% across 100 care homes. And even here with 10%, you can see that you can make huge savings, but also you can lose a lot. Also save a lot from missed avoidable hospitalization due to false negatives. So 3 and 10% are also quite conservative, since we saw that 6 to 17% is the error rate of a hospital-trained nurse. And in community settings, the error rate is much, much larger. Just to give you a bit of impact as well, outside of the respiratory rate example, but generally what we've seen the healthcare community in the UK respond, how we've seen them respond to our end-to-end system. We've seen that in terms of carers or community workers, we've sort of improved their interactions with GPs. So 86% of them said that they have better interactions. They also understand a resident's overall health in a much better way because they're receiving feedback and they're seeing how their patient is doing very rigorously. The GPs have also reported improvements in quality and efficiency of care, and 71% of the GPs also reported improvements in flexible working allocation of resources, so using them where they are needed, basically. And proactive monitoring has increased from 42% before using Fibris to 78% after embedding it. So we're really seeing a trend here in a more end-to-end system and in a more communicative system and in a more remote monitoring fashion. So going back to our first slide and going back to our mission. So our mission is to have AI-powered diagnosis and accelerated treatment access to every household around the globe. As we've seen, these are the requirements and challenges for AI in community healthcare, But what we are doing to respond to that is we are building a data refinery. So we have a lot of focus on capturing clean signals and cleaning and refining noisy ones. In terms of scarcity of data, we have it integrated into our system, into our product, to have end-to-end data collection from communities and from doctors' sides. And finally, in terms of scalability, we are committed to capturing data from diverse data groups and to validating our models across all of them. So that's it for my presentation. Thank you so much for listening, and I'm happy to take any questions.
Thank you for the talk. Okay, this is the Q&A session. So if anyone has questions, please raise your hand, unmute yourself, and ask the question, or please send out the question in the chat.
So I have a question that was submitted by some of our audience through the registration form.
Sure.
So this is from a Master of Science of Machine Learning, a Master's in Machine Learning student. He asks if he has no experience in medicine but wants to explore a career in the field. How would you recommend going about it?
Okay, that's a really good question. And I myself was actually quite scared to go into the field of healthcare. My background is in electrical engineering and then communication systems and then machine learning and finance. But I don't think this is a cause for concern at all. It's very common for people in the machine learning field to switch between fields, and there's no prerequisite on what kind of background in that particular field you need. So I didn't even prepare in terms of clinical knowledge before joining this company, and you just learn while you work. So in our company, for example, we have clinical experts. We also have a deep-rooted curiosity to understand these things. You also need this kind of curiosity to learn, because as you can see probably from this presentation, you can't just work with AI models. You need to learn the entire ecosystem, but this is definitely possible to do on the job.
There's a second question submitted through the form as well. And there seems to be many potential applications of machine learning and AI in healthcare. What do you think is the one potential use that is often overlooked?
So from my observation in the field, I've noticed that a lot of AI in healthcare is focused on image data, so X-rays and MRIs and things like that. But there's a gap in the field. Actually, there's two, one of them which I've already discussed, but I'm going to repeat it anyway. But the one that I was going to mention is in terms of audio signals. For example, stethoscopes and coughs and things like that. There is a little research being done there, but this is extremely valuable to the healthcare system. And the second one, which I've also sort of mentioned in my talk, is that a lot of the data that's present now and a lot of the research that is being done is using hospital data. And this just doesn't scale outside of hospital settings, which are very quiet and very clean and everything. So there is a gap in community healthcare, which we are hoping to tackle, but it's a large job. So I encourage people to join the force.
I myself have a question as well. Like, as a machine learning engineer, like, which part of the project have you worked in?
Sure.
Like,
Yes. Sorry, you were saying something else?
No, I'm
okay. Yeah, so I'm working on different fronts. One of them is personalizing healthcare. So what's normal for my body might not be the same as what's normal for your body. So what happens is we're using monitoring of patients longitudinally to determine what is a good personalized healthcare plan for every single patient individually. I'm also working on monitoring a patient longitudinally to detect deterioration early before an emergency happens to them. Another thing I'm working on is when we gather labels from or annotations from clinical and non-clinical annotators in the field in order to determine what is the ground truth. We need to fuse those labels. So we need to merge those labels. And it's not an easy problem because these are not just classification labels like 1 and 0, but they are real numbers like respiratory rate could be 16 or 17 or 18. So how to best fuse them and at the same time maintain a gold standard standard basically for what is the ground truth. And another thing I'm working on is monitoring the entire ecosystem. So how do you make sure that your product is safe from a clinical perspective and that you're gathering insights that can help you to improve your product?
Does anyone have any more questions? Actually, there's one more question. There's pandemic with COVID-19 being a really serious problem. What has Fibris worked to resolve this problem? Yeah.
Yeah, it's a great question. So we have actually started to launch in elderly care homes in order to help elderly people during the pandemic. So we realized that they are the most vulnerable group of people in the UK, and we wanted to provide them with high quality healthcare assistance, but also most importantly, remote monitoring so that doctors don't have to be there. They can receive care and treatment remotely every day and to have close monitoring. So we've had to focus on that. And we're also developing COVID checkup. So it's a COVID specific checkup that could evaluate the percentage that a patient has COVID or not. This is not deployed yet, but it is work in progress.
What kind of extra checkups are you planning to do with the COVID-19?
So there are some clinical guidelines on how to detect or what are the main symptoms of COVID. And we're going to follow these clinical guidelines because we have to comply with the clinical regulatory guidelines, basically. So these involve capturing signals with the same devices that we have now and adding some questions to the questionnaire. Yeah, just to add to that, we have started with 4 digital devices. These devices capture the sort of foundational vital signs of patients, so they can help us to really build the building blocks leading up to diagnoses and triage of different kinds of diseases. But this is basically the start, and we're definitely going to expand in the future. But yeah, these are sort of quite common vitals, which we can use to determine several diseases.
Thanks.